The next section will be a presentation of a number of clinical cases that illustrate how this new bone physiology concept can be applied to designing operations for bone regeneration, and also to understand how common operations that we perform every day actually work. The first topic will be that of osseointegration. Osseointegration has been performed for many years and basically still follows the protocol set down by Branemark. When Branemark originally proposed this concept of placing titanium dental implants into living bone for the purpose of creating an anchorage unit for prosthetics, the assumption that he put forth was that there was a special relationship between living bone and titanium implant surfaces. His research reinforced the concept that there was some type of special relationship, special attraction between bone cells and the titanium implant surface. He published a number of articles and produced images that reinforce this concept. Furthermore, over many years, following the protocol produced basically predictable results, so that the assumption was that the underlying basis of the system, that bone simply had an attraction to the chemistry of the titanium surface, was indeed valid. However, just because something appears to be one way does not mean that it actually is. Many times we conclude that a process is in place just because it seems reasonable and that there are no other available explanations. This bone biology system that I'm proposing provides an alternative explanation as to what we see, and therefore we need to maintain an open mind as to whether or not the original assumptions of Branemark were actually valid. Now, membranous bones heal in the adult based upon the response of the Sharpey's system to the original injury. It turns out that the embedded Sharpey's regulatory system within living bone is damaged during surgical procedures or trauma. The evidence shows that the healing process after injury of this system follows a specific sequence which is identical to that of the original generation of the bone in the fetus, as shown by Gene Aaron. Gene Aaron and Dr. Scarry were able to show that in the adult, bone osteotomies, similar to those made in dental implant surgery, healed in a very specific sequence. Rather than the dependence on attraction between bone cells and titanium, Aaron and Scarry showed that the defects healed in a sequence which involved penetration of the defect by budding Sharpey's fibers. That was then followed by consolidation of bone following a pattern that was the same as that put down by Harville. Now, this is a clinical example. This image shows a fractured dental implant that has been in place in the maxilla for many years. The fracture of the implant renders it unusable, and so the treatment plan is for removal. The removal process is done in a standard way with a trephine burr. The trephine itself is a rather traumatic method to remove the implant from the bone. It cannot be considered to be on the level of the atraumatic osteotomy that was used to place the implant to begin with. The result of this osteotomy is that the implant is then removed. In this case, the implant itself was embedded into the sinus floor, so that during the luxation of the implant and the layer of bone surrounding it, the sinus floor has been disrupted as well. So this defect is a relatively large osseous defect. It is through and through involving disruption of the osseous sinus floor and the sinus membrane, and the dimensions of this hole far exceed that of the original osteotomy. In fact, when an oversized implant is placed into this defect, there is a gap between the titanium cylinder and the bone 360 degrees around the cylinder, and there is no bone at the apical end because the sinus floor is missing as well. In addition, this implant is a plasma sprayed dental implant. It is not of the modern design of implants that have special coatings and SLA surfaces. This is a basic primitive implant, which is basically an additive surface with titanium plasma spray. As you can see, there is no contact between the living bone and the titanium cylinder. Now, if one removes a dental implant and leaves the space to heal on its own, what we see, according to the principles set down by Aaron and Scarry, is that Sharpey's fibers bud into the defect, and then following the movement of fibers into the lumen of the defect, bone follows the fibers, and then the defect is filled. The fibers are first, then the bone follows afterwards. If we suspend a dental implant in the middle of this defect and hold it in a relatively static and stable condition utilizing a small bone plate, what we see is that the same healing process occurs. The bone fills in from the surfaces of the osteotomy, surrounds the implant, and heals the new implant in an osseointegrated way. This violates the basic concept that was set down by Branemark, who felt that it required a physical contact between the living bone and the titanium cylinder to achieve predictable osseointegration. In this case, there is absolutely no bone that is in contact with the cylinder, yet osseointegration occurs anyway. So this clinical example shows that the dental implant has been placed, and then a small bone plate is adapted to hold the implant in place so that it doesn't move or fall into the sinus. Two small screws are placed at a distance from the osteotomy to secure the implant. The principles of healing would suggest that then the gap between the implant and the bone will be filled by the progression of Sharpey's fibers into the gap and then subsequent fill with living bone. Now, after 4 months, we re-enter the site and we see that the implant is basically stable. We remove the bone plate, and it is clinically evident that this implant has healed into the bone. However, the test is really to load this implant and to follow it for many years. So this new implant has now been restored and is under function for a number of years. You can see on the radiograph two important features. Number one, that the implant itself is fully invested in living bone, and that the living bone is of an architectural pattern that supports the concept that living bone has grown towards the implant cylinder. The second feature we can see is that the sinus floor has reconstituted itself just above the hemispherical apex of the implant, and there is a continuity of the sinus floor itself.